Today's speaker is Dr. Marie Brown, who is the Director of Practice Redesign here at the American Medical Association, a Professor Emeritus at Rush University, and proudly a practicing physician in internal medicine for over 30 years. Today, Dr. Brown will be presenting on Taming the EHR. Welcome, Dr. Brown. It's a pleasure to have you with us here this afternoon. I'm going to go ahead and hand it over to you.
Great, thank you. And thank all of you for joining us today. We're recording this in April of 2021 in the midst of a pandemic none of us could have ever imagined. So I know that you are incredibly busy and so stressed. So I hope you're sitting down, having a cup of coffee, or going for a walk. And hopefully over the next 45 minutes, we will provide you a few tools that will help you save time. Now we know that EHRs have transformed our work in healthcare, and none of us want to go back to paper. However, it's a source of great frustration, and it can lead to burnout. Tim Cook, CEO at Apple, said that we want technology to be there when we need it and empower us to communicate with others better. But sometimes it doesn't feel that way. So hopefully we will be able to address some of the frustrations. I have no conflicts of interest. I will share with you a picture of my team. I began working in internal medicine at an FQHC. When that closed, Dr. Forbes there on the right and I moved down the bus line and went into private practice, a two-person practice for almost 20 years. And most recently, I joined Rush University. So I went from paper to implementing my own electronic health record called Amazing Charts. And then when I joined Rush, a large integrated center here in Chicago uses Epic. So I will be sharing some of my experiences with Epic, and hopefully most of what we talk about today will be relevant to all the other vendors as well. The agenda, we're really going to focus very briefly on the impact of the electronic health record on burnout, your well-being, and the patient experience. We're really going to highlight that you have more control than you think. And we're going to spend most of our time talking about time-saving tips and tricks. And I want to highlight that of the 3 strategies at the American Medical Association, the number 1 strategy is this: removing obstacles that interfere with patient care. Because everything we're trying to do here is to save time, not so that we can go home early, but that we can spend the time we have with our patients looking them in the eye and having a meaningful discussion, work to get that diagnosis, and develop a trusting relationship. So here's the pledge for strategy 1. And I'll highlight that technology should be an asset and not a burden. We're going to identify simple changes that you can do this afternoon, highlight the use of teamwork and planning so that we become inspired about what we were called to do this important work for. And I like this quote from Don Berwick. I'll let you read it, but talking about this calling and that what we do touches the highest aspirations of our civilization. And if any work should give us satisfaction, this should be it. However, we're often very, very frustrated. And the source of our frustration may be, more often than not, the electronic health record. But we blame the electronic health record for many of our frustrations. And it may be the tool we see, but the regulations, the performance measurements, and everything that hits us through that computer screen is not related completely or provided by the vendor. It is sometimes helpful to separate CMS regulations, performance measurement, and the vendor capabilities. But what's happened over the past 15, 20 years is truly a knowledge explosion. And I coined this talk, 1,600 guidelines in 17 minutes. For an internist like myself and geriatrician, this could not possibly be communicated with the patient. We cannot apply 1,600 guidelines in the short time we have. We have to use team-based care. And we need to use the electronic health record, because with that amount of knowledge, it is simply not possible to do that in the old-fashioned paper charts. However, in this study done by our vice president, Dr. Christine Sinsky, also an internist, she looked at a time and motion study in 4 specialties: family practice, internal medicine, cardiology, and ortho. This was done with a Dartmouth Hitchcock, and they found that for every 1 hour of face-to-face time with a patient, there were 2 hours of documentation time. And more often than not, 1 or 2 hours of work was taken home. We can't take the patient home, but we can give our undivided attention to the patient, but then we have to take that documentation time, that documentation work home, which takes us away from our family and any time for ourselves. Other publications have confirmed the same data. Here in the Annals of Family Medicine, primary care physicians spend half of their workday, nearly 6 hours, interacting with the EHR. And again, work after work. And we know that the use of the electronic health record and sometimes the frustration or the meaningless work that is required there is associated with stress and burnout. Also at the American Medical Association, we've done research looking at metrics for assessing physician activity. And I'll blow this up a little bit. And these are proposed core electronic health use measures that hopefully would be applied across all vendors so that we can compare and we can see what the total EHR time is, work outside of work, for compared to 8 hours of patient care time, and time on prescriptions, inbox, and the use of teamwork for entering orders, as well as identifying and measuring the amount of undivided attention we can give to our patients. Because that's what patients want. They do not want to see our back while we're struggling with the electronic health record. This is all about delivering quality patient care and the patient experience. Very quickly, I'm going to review what burnout is. And it is a stress reaction characterized by these 3 things. Sometimes it comes in the form of depersonalization, referring to a patient not as their name, but the train wreck in room 1, emotional exhaustion, I just can't take it anymore, or feeling that the day you spent was not what you were trained to do, that you spent most of the time doing meaningless work, and feeling like, what's the point? All I did today was click buttons and document for billing. These are many of the causes of burnout, many related to the EHR. Here, many of you know the effects on the physician. We know that many are exiting practice or doing part-time work, hopefully not having family problems at home or suicide. But the effects on the patients, the teams, and the organizations are significant as well. When a physician is burned out, patient satisfaction, trust, adherence goes down. And we know that a burned out physician is more likely to write more referrals, order more tests, make mistakes, and the people around them will have more staff turnover. And it costs organizations. A very effective way to decrease burnout and to manage the documentation burden is to go part-time. So many physicians are going from 5 days a week to 4 for clinic. And so they're working 0.75%. What are they doing on that day off? The documentation required by the EHR to give good quality care, which they will not sacrifice for the other 4 days. So an organization looks at this, and on average, many of their physicians are going part-time. If you have 600 physicians and they're all on average 0.75, you lost 150 physicians, but you're paying full benefits for all those physicians. So that's something to think about when we want to invest in some of these time-saving tools that we're talking about. And what brings joy to a physician? Really pride in their work. At the end of the day, we're not afraid of hard work. We wouldn't have gone through medical school and residency if at the end of the day you can say, I saved lives, and everything I did today, I needed my training and my skill set to do. It's when we're doing meaningless work that is so frustrating. We think of the relative causes of burnout as the organizational culture. Only 20% may be personal resilience, and I'm going to focus today on the efficiency. A couple notes on the organizational culture. This is an interesting article on the business case for investing in physician well-being, and I encourage you to look at that to find out where your organization is. Are you a novice and thinking of personal resilience? Or are you proficient or expert and your leadership understands the burden and is working to minimize the burden of documentation? So we're going to focus on the clerical burden and taming the EHR. And to do this work, this kind of efficiency work, it's important not to think like a doctor. Now that may sound strange, but we are trained to think of the exception. We are trained to think that every headache comes in is not a tension headache, but is a brain tumor or subarachnoid hemorrhage until we do a history and a physical and prove otherwise. If we didn't think like that, if we weren't trained to think like that, then we're going to miss that one patient who comes in with an unusual diagnosis. But to do this work, we need to think like an efficiency expert. So if we're working on something that would save 2 hours a day, but it'll only work for 50% of the people, your patients, then you're only going to save an hour a day, not 2 hours a day. But we still want to implement that change or that opportunity to be more efficient. So this is one of the biggest take-home points I'd like to leave you with. And quite often we blame the vendor for our concerns and some of the unnecessary work we think we're forced to do. However, we have seen around the country that the compliance department or your IT department, risk management or coding are actually overinterpreting the regulations. And I'll show you some of those examples. So you may have much more control than you think, and working closely with the compliance department and these other committees to make sure that they're accomplishing what they need to accomplish, but with the understanding that the user experience should be incorporated into any decisions that they make. Here's an example. This is a screenshot from Epic. And in each patient chart, I can go to my patient care team and I can turn off notifications of tests that I have not ordered. And it's simple to do. You can do it with each patient. You can turn them on if you want to follow what a specialist or somebody you've referred to is doing or how they're doing in the hospital. But for most of my patients, I trust my specialists, I trust my hospitalists, and I'll look at that chart and review everything when I see the patient. I do not need, as it's ongoing, to have all of that information when I am not in charge of that patient. I don't need to see what my other colleagues are doing. When I turned off these notifications, my inbox decreased by almost half. And it's also a patient safety issue. If you're getting notifications of orders that another doctor wrote, for instance, a cardiologist ordered electrolytes and your potassium and that patient's potassium comes back low, the cardiologist ordered it, it's coming into your box because they copied it. Do I address the low potassium or does the cardiologist? And she may think I'm doing it, I may think she's doing it, and that's where patient safety and the attention to that abnormal test may be missed. Your in-house IT team can default all of your patients to either notifications for admissions, discharges, and transfers to being off or on. At one hospital, the CMIO told me that for the primary care doctors, they turned it on, the default was on, and for all the subspecialists, it was off. But they said they were rethinking that. Again, you can always turn it on if you want to watch closely what other doctors are doing for your patient. But I found that it was not necessary. I reviewed them when I saw the patient. There are also examples of security issues. In one hospital here in Chicago, a pop-up notifying the physician or the user about the privacy concerns of the hospital popped up every single time that the doctor logged on. This would maybe occur 100 times a day. Now, you delete it, or you hit OK, and it goes away in less than a second. However, this was brought by the EHR, not by the EHR vendor, but by the hospitalist compliance officer. And if the compliance officer's job description and what leadership wants that compliance officer to do and only do is be sure that security is intact, then this is what you're going to get. But if leadership directs the whole hospital to also be sure that the time required, the necessity of the alert is part of their job description, then this may not happen as often. When you get an alert like this, when it happens 100 times a day, that could be 10 minutes a day, an hour a week. That's 52 hours. That's 6 days. That's a week of work for you. And we know that when you see this, it distracts you from the task at hand, and it can take up to 24 minutes after a distraction to regain focus on a task. So the first thing we encourage you to do is stop doing unnecessary work in the electronic health record. So I've already alluded to getting rid of copies that you don't need to see. The things that come to your inbox should only be things that you need to attend to, not FYI. We have a Steps Forward toolkit called Getting Rid of Stupid Stuff. This was written by Melinda Ashton, Dr. Ashton, after she wrote a piece in the New England Journal and was kind enough to author this toolkit. It shares how she went about finding things, asking physicians and nurses, the clinicians doing the work, what are they doing that clearly does not add anything to the experience or the physician health or to the patient health. And sure enough, they found wonderful opportunities that saved hours throughout the organization. In the toolkit are opportunities to show how to roll this program out in your organization with templates and emails, and how to sort them after you get recommendations or suggestions from the workforce. She suggests sorting them into just do it. It's simple, simply turn it off, or the IT department turns something off, like I just mentioned with notifications, and that could be take less than a week. When I first went to Rush University, every time I ordered a non-controlled substance, I had to enter my username and password. Dr. Dan Dunham, who came from another hospital, said, well, we don't do that across town. Took him a few weeks to find the right person to call, but once he did, they turned off that requirement. That one phone call probably saved thousands and thousands of hours for the physician and clinicians throughout the organization. And then there'll be some that take longer, maybe redesign or re-education, maybe 2 weeks, and some things that simply are not able to be done. And there are many examples in the toolkit. I mentioned some of them. Another one that is very common is how quickly the computer automatically logs you off. And this is not vendor specific. This can vary in location within your organization. So in the ER, where the computer is very public, we'd want it to automatically sign off for security in a very short period of time. However, if you're having a visit alone with the patient in an exam room where we don't have to worry about security, it should not be as quick, because while you're trying to talk to the patient and give them your undivided attention, you're trying to remember to move the mouse so that it doesn't automatically sign you off, because then it's 30 or 40 clicks to sign back in again, unless you have radio frequency ID, which hopefully many of you do, which obviates the need for any of that. So there's many opportunities to stop doing unnecessary work or get rid of stupid stuff. And many of those can save you hours each day. And just last month, the AMA published a de-implementation checklist. This is also housed on the resource page of the Getting Rid of Stupid Stuff toolkit. And you can share this with your compliance department, IT department. It's a 2-pager. I'll highlight just a few of the pages, but there are many opportunities here to stop doing things that are unnecessary. And we know that physicians themselves are often in the best position to recognize those unnecessary burdens that don't bring any benefit to the experience of the patient, the coding, or the physician experience at all. So it's broken up into EHR, compliance, and quality assurance. The compliance allow verbal orders in low risk and in crisis situations. We've seen that in the COVID crisis, but verbal orders can be allowed in low risk settings. This list has also been viewed by Joint Commission, and they have agreed with all of the recommendations here. We need to reduce clicks as often as we can and eliminate unnecessary requirements like attesting to a possible pregnancy in a man or woman over 60, and reduce all those inbox notifications. And I'll share with you what one group in Boston did successfully. We also have a page called Debunking Regulatory Myths, so that you can see where the initial regulation lives and how it may differ from what your compliance officer or your IT department is doing. So we don't want to do more. We don't want to overinterpret the rules. We want to follow the rules, but we don't need to overinterpret them. So here in Boston, they set out to save time. The technology solutions included widescreen monitors, dictation, in-basket reduction efforts, and they were very successful. Just widescreen adoption alone saved 60 million clicks, and they estimated that the click savings was $1,500 per day per provider. And if you average that out to maybe 5 seconds of seeing something that pops up that you have to accept or hit next or get rid of, on average, maybe 5 seconds, that's 2 hours a day per provider. So that's an enormous amount of time saved. They eliminated ADT, admissions, discharges, and transfers, and got rid of 300,000 messages a year. In some organizations, paper is still coming over, and we have to sign those papers, the home health, physical therapy, durable medical equipment. Then that paper is sent to be scanned. In some organization, that scanned document comes back into their inbox to be checked off again. Well, if it's already been signed, you've already reviewed it, it simply does not need to go back in to be reviewed once again. That's double the work. And if we talk to our specialists and work together as a team across the medical staff, copied charts were necessary when we didn't share the electronic health record. Now, if I want to see what the cardiologist did, I have access in the computer. So do we really need for a routine referral to a dermatologist, a cardiologist, a pulmonologist, especially if they're following the patient along with you? Do we really need to see that? Or would it be more efficient to look at that chart in preparation for when I'm going to see that patient maybe next week? So it has been done and it can be done. There's opportunities to eliminate notifications, duplications, copied charts, anything that's FYI, because it all leads to burnout and wasted time and time away from your patient, most importantly, and of equal importance away from your family. We can add standing orders and protocols and standing labs, and I'll highlight that we can refill meds for 1 year, having the refill burden for your nurses and your staff. There are many quick wins. I've mentioned some of them. And implementing dictation. I know I started dictating when Dragon first came out years ago and found it very awkward. I picked it up again a year ago and was amazed at how far the technology had come. So if you haven't used it recently, You may want to try it again. And I found it was very effective, rarely got anything I said incorrectly. And in fact, I found it quite a time saving because I would put in the plan, I would look at the patient and discuss the plan. So while I was telling the patient what the plan was, getting a lab, going to physical therapy, whatever, I was dictating into the chart at the same time. And the patients loved it. My documentation improved, and I closed the chart when I left, before I left the room. We have several toolkits on EHRs. I'm going to highlight a few. EHR in basket for improved efficiency. And again, these are open access, written in a very conversational tone. Usually takes 20 or 30 minutes. There's videos and resources that you can use associated with it. Adopting OpenNotes. Tomorrow goes into effect the Cures Act, where your patients have to have access. You have to provide access to their note. And I'll share with you how we can use autocorrect so that the patients don't call trying to understand what an abbreviation you might have used is, or for explanation of the note. These are three more. We have one on telemedicine, very timely last year, and one on optimizing the patient portal. Many organizations don't know that internally you can decide how long you can limit the number of characters that the patient is able to write, so that it may be limited to 100 or 200, but this stops the patient who is writing 500 or 1,000 words, which certainly is not appropriate for a patient portal conversation. And then there's electronic health record strategies for thriving, which you'll see much of what I'm talking about here. There are some simple things that we can do according to standing orders that a physician doesn't really need to have that MD or DO to sign off on. So we can make standing orders or protocols that test strips, glucose test strips, can be refilled by an MA, depending on your state rules, or your nurse. We can get rid of discharge summary notes, especially when they say that when you open it up and it says no notes of this type exist for this encounter, because this is very, very frustrating and completely unnecessary. One of the benefits of the electronic health record that I greatly appreciate is being able to postpone a laboratory result. If it's not emergent, like a slightly low vitamin D level, I could talk to that patient the next time I see them, maybe next week or 2 weeks. So I can, instead of calling that patient today, I'm going to have that discussion with them next week. So I'm going to postpone this lab so that it'll come into my inbox the day before I'm about to see that patient. So with one click, I have addressed it, I haven't ignored it, and I'm going to be able to have a much more efficient conversation with the patient face-to-face about a slightly abnormal lab. I also especially like the opportunity to use the electronic health record to remind me of something very important that the patient that I want to be sure that the patient follows up on. Perhaps it's an incidentaloma on a CT scan for lungs that was done for some other reason. And I want to be sure that they get another lung scan to make sure it's stable in 6 months. So I can send a reminder not only to myself, but to my MA in 6 months. So it'll pop up again in 6 months. I sleep better at night knowing that I'm going to be reminded, as is somebody else, to be sure that that patient did follow up so that we don't miss a growing malignancy or some such medical problem. We also can streamline our problem lists. This is there's an example of wanting to put obesity in the problem list, but putting in the BMI and whether it's associated with other comorbidities is very time consuming. With a few minutes, you can save these and you can find a way to streamline it so that you're not clicking 4 or 5 different ways and frustrated to simply want to document that a person has a BMI of 35 and has obesity. Similarly, with the problem list, we have to associate it with when we order tests. In some electronic health records, you can click the top where the diagnosis is, and it will auto check all the labs that you have that you want to associate with that diagnosis. So 1 click replaces 4 clicks. And these are simple tools and tricks that take time to get to learn, but 10 minutes can save you 10 hours in the long run. Another tool that I found helpful that meant that actually a patient of mine shared with me who also used Epic was to type in .risk, and what will automatically populate is the atherosclerotic cardiovascular disease score, so that you know the risk score, so that you have a calculation of whether the patient is eligible for statin, for example. And I found that this was very helpful because I used to put it on my phone, which I had to add in the total cholesterol, the HDL, the blood pressure, whether they're diabetes or a smoker. That was a tremendous amount of time, but it's necessary to do when you're trying to calculate somebody's vascular risk. So this is automatic. And what I found with patients is I would frame the discussion about whether they needed a statin or not and what their risk was, if we were trying to get them to stop smoking or get their blood pressure under control. I would say that if it's less than 5%, this is what we need to do. It's 5 to 10%. Here's the conversation. If it's over 10%, that means you have a 10% risk, and that would be probably a time we'd want to definitely put you on a statin. And then I would have the patient, I would type .risk, and I'd have the patient actually press the enter button, and then would pop up a number. And I was surprised if it came up like this, 20 or 30%. They go, oh, I guess I would benefit from the statin. And if it came out at 2%, they'd say, oh, this is great. I'll keep doing what I'm doing, and we'll calculate this every year. So I think the patient engagement was very helpful here as well. We can also improve adherence and improve our experience and the patient's experience by using indication prescribing. If you set up your electronic health record so that your top 10 drugs that you most commonly use, you can add into the instruction, for instance, you're ordering atorvastatin, you could add into it that this is to lower your cholesterol and prevent heart attack and stroke, so that the patient understands why they're taking it. You don't have to write that over and over again. Every time you order atorvastatin, that's what will pop up. And patients and families really appreciate that, and that's called indication prescribing. We also have a toolkit on medication management, talking about or teaching how to move chronic med refills from 90 times 1 for 6 months to 90 times 4, call me no more. And clearly this saves, and I did it in my practice, I've facilitated other organizations doing that one little change in 6 months can result in an hour or 2 savings for doctors and nurses. The patients like it. Actually, they love it because they only have to worry about getting it filled once. And if you can synchronize them so that all the meds come due on the same day, that's even better. Now, every physician knows and is thinking of the one patient where they won't come in. So you continue to see the patient as often as you need, but you don't punish all of the patients who wouldn't come in anyway by making them come in for double the refills twice a year instead of once a year. And you're not punishing yourself and your staff. So you free up an hour or 2 a day so that you can reach out to the patients who are missing their appointments or who you were using the prescription to hold them hostage so that they could come in. And of course, they'd go a week or 2 without taking their medicine, and that is not ideal for their adherence or their blood pressure. So streamlining that is very helpful, and you can default. I just was talking with a physician in DC yesterday. They had an upgrade with Cerner, and they had an opportunity to change the default to, instead of 90 times 1 to 90 times 4, and they did that. So the default is 90 times 4. And you can change it to 3 or 2 or 1 or 30 times 1. But the default is the time saving benefit. And again, saving an hour or 2 a day, night calls, weekend calls, patient satisfaction goes up. And of course, you continue to see the patient as often as you need to. But imagine a day when you're not writing or responding to a phone call, a fax, requesting a refill for a chronic med. We look at any refill that comes in when the patient isn't scheduled as an error and an opportunity for improvement. Another one of the tools that I found in Epic extremely helpful is similar to what you all have if you have an iPhone, autocorrect. So these are not smart lists or embedded links or text macros, as some of the vendors call it. This is simply replacing your shorthand. So you know how you write a quick note to yourself. It might be a 60-year-old with COBRBPR, short SOB. So that would turn into a 60-year-old woman complaining of bright red blood per rectum with shortness of breath and dyspnea on exertion. And this is going to be extremely important now that all the patients will receive and have access to all of their notes. So if you use jargon, one time you need to put in your specific to your specialty, what you abbreviate things, PAD, peripheral artery disease. If you put that in once, every time you write PAD and then hit the space button, it will write peripheral arterial disease. So this probably saved me a good hour a day and made my notes much more readable for my colleagues as well. When we are prescribing, we can also write a note to the pharmacy so that in addition to 90 times 4 for a whole year, we can synchronize them so that I wrote SYNC, and that automatically populated to a note to the pharmacist to sync the medicine. So all the chronic meds come due on the same day once a year and disregard all prior prescriptions for this medicine. Many of the pharmacies are trying to do this. One retail pharmacy calls it Save a Trip, and patients love it, their families love it, and it's a great time saver for you as well. Another concern is trying to find the correct order. Sometimes you want to order a simple x-ray or a simple mammogram, and you'll have 2 or 3 pages of choices. And this is very frustrating. You might order a test, once a month, and you find it. You have to ask somebody to find it. You have to call radiology, which is the right one, especially for an MRI or MRI of the spine or brain, something a little unusual. But if you know that there's only a few of these, once you find it and put it into your favorites, you're not going to have to waste that 20 or 30 minutes, or worse, get the wrong test pre-authorized and waste everybody's time, including the patient, and put it in your favorites. And this is, again, take 10 minutes to ultimately save 10 hours. So turn off the notifications, communicate with your subspecialists regarding copies. Consider asking or if there's subspecialists on the call, changing the way you format your note, your consult to the primary care, the referring doctor. Instead of the old-fashioned SOAP, subjective, objective assessment and plan, put the assessment at the top with the plan underneath. And if the referring doctor wants more information, they can scroll down further for the subjective and the objective. And I appreciate my subspecialists having a copy letter, as we did when we communicated via post, saying thank you for the privilege of sharing the care with your patient. But there's no information. It's a thank you note. And it takes me 2 or 3 clicks to get past that. I appreciate that, but I don't need to see it with every single consult that comes in. I really just want to see the assessment and the plan, and a thank you note once a year to thank me for referring a patient to them would be more welcome. I've seen physical therapy appointments in my inbox with 20 that are clearly unnecessary. So talking to physical therapy or having your IT people make sure that anything that goes into your inbox needs action. And use autocorrect, favorites, smart lists, tests, macros, whatever your vendor provides. With that, you can easily save 3 to 5 hours a day. And in addition, I'm going to highlight a couple of other toolkits that will achieve that and get us back to having time to spend with our patients to do that difficult differential diagnosis of a new complaint, that building trust, and that motivational time that requires a relationship and time to develop that relationship. These are a few of the categories for the toolkits that we have. And here are some listed. I'm going to highlight just two: prescription management and pre-visit planning. And with pre-visit labs, which can be protocolized and done with your team, so the patient has the labs done, completed, your A1C, your BMP, within the week of seeing you, so that when you see the patient, you have everything you need, so that you're not playing phone call, getting the test that day, and then calling them back with escalation or de-escalation of therapy, because it's difficult to get a hold of patients now. When an organization did that, phone calls went down 90%, as did letters. Patient satisfaction went up, and nurses and physicians had much more time to care for their patients rather than trying to track them down. It can save 8 weeks per year with synchronized prescription renewals as well. And that is an enormous savings. And most of the nurses that I speak with do not want to spend the time talking to every retail pharmacy in the city. It is not a good use of their training. And it can save money. If you save an hour a day, it can be of your staff. It can be, you can perhaps replace or have an opportunity to hire additional staff to do this work. We really want to be enabled. We are engaged. We didn't go through all this training. There's no question that we're engaged. We want to make sure that our IT department provides training on the clock, or give RVUs for the training. At least make somebody whole. If you're involved in committee work, don't have the physicians that you need to talk to the compliance team or the IT team to be penalized because they're not in clinic and they're losing RVUs. At least make them whole. And measure work after work. In Epic, it's called Signal. Other vendors have similar ways to track that. We have to get away from the physician. There I am with my patient playing on the phone, and I'm trying to find, I'm the billing clerk, the pharmacist. I'm trying to find medical records, a transcriptionist. It's not sustainable. This is a picture of Dr. Sinsky, our vice president, who says, we wouldn't think of asking lawyers to record the legal proceedings, so why do we expect that we would do the same? It just can't be done. So team documentation is critical. This is Kevin Hopkins, also one of our senior physician advisors at the AMA. He also works at the Cleveland Clinic and Family Practice, and he has in-room support. To have that second MA, they thought it would take, they'd have to see additional 2 patients. They were easily able to see many more than that, and the work was all finished at the end of the day, and they stayed on time. Brought tremendous joy back to their practice for the entire team. University of Colorado has provided in their family medicine residency an increased ratio of medical assistants to even people in training so that they get used to this teamwork. And we also have a toolkit coming out later this year on how to recruit medical assistants called Medical Assistance Recruitment and Retention, and we've done a webinar on that as well. We want to match the work to the worker. With the increasing complexity of the work, we want to be sure that the right person is doing it. And we don't want somebody who is highly trained to be doing work that someone else could do. We want the doctor to be developing the diagnosis, building relationships, and we want to be sure that what you don't need an MD to do could be safely handed off to somebody else on the team. And that's that sweet spot. Again, not, let me just in few sectors of the economy is the highest level professional doing production, customer service, and clerical work. And it's just not sustainable. So we want to be sure that we incorporate team documentation, and that involves your IT team providing access for the chief complaint, the HPI, pending orders, depending on your state rules for scope of work, can be entered or at least pended so that the physician doesn't need to do all of that. Because if we do this, we can eliminate 1 billion clicks a day. Here are, I strongly encourage you to look for a lot of this information on stepsforward.org. Again, it's open access, don't need to be a physician, don't need to be an AMA member. Lots of videos, lots of podcasts, many success stories. And they're all, the goals of the Steps Forward program is to really help eliminate waste from our workflow so we can get back to face-to-face time with our patients and improve patient care to improve the health of the country. So the take-home points are these. The burden of the EHR leads to physician and team burnout. It really affects the cost for the entire organization as well as quality of care. We can stop over-interpreting the regulations at the local level and stop doing unnecessary work. Improving personal resilience, meditation, eating right, maybe 20%, but it is really the efficiency of the workplace and the culture in which we work that is 80% of the causes leading to burnout. Team documentation saves time and money and improves patient care. And with a few of the opportunities that I hopefully shared with you over the past hour, hopefully you'll be able to save many, many hours so that you can do more meaningful work. Because the principal driver of physician satisfaction is really delivering quality care. So I hope that that has been of some help to you. I know it was vendor specific because this is the one I use, but most of the vendors have similar programs. And I hope that we will all be able to tame our EHR and get back to doing only meaningful work so that we can give the best care to our patients and improve health outcomes. So thank you very much for your attention, and I'll hand it back to our team.
Brittany, thank you from a staff standpoint. Marie, thank you very much for your great presentation. If you have any questions, please be sure to enter them into the chat, or the Q&A is preferred. There was a question whether or not this will be available. It will be a couple weeks after the presentation. We load it up on the website, and you'll be able to then see the whole presentation. And then Marie answered the question about whether or not Steps Forward is open access, which it is. And so these modules are available. It's part of the AMA's belief in helping the profession regardless of AMA membership, though we do encourage anyone who's not an AMA member and is eligible to join us. I do have a question, Marie. A lot of talk is about patient-centered care, and you teased a little bit about OpenNotes, but using the example of the annual chronic medicine refill, it still seems to be physician-generated. Has there been any concept of saying, well, just let the patient reorder their medicines directly and notify the physician that they're reordering? Have you heard any discussion about that as being an option?
Thanks, Jim. I have not. I think the opportunity for when medicines become over the counter, you know, they're safe enough. I think there are some drugs that probably fit that category, but that is not something that I think we focused on. I remember, I'm showing my age here, when non-steroidals were prescription.
That's right.
And there may be, you know, some of the drugs I highlighted during this are so safe and don't need monitoring that, you know, they may someday become accessible. I think the opportunity I would worry about adherence a little bit more if we didn't, people think that it's that prescription, it makes it a little bit more important. And cost is less of a barrier now. 80% of meds, chronic meds, are generic. And so we also should be paying a lot of attention to that. And if we can improve adherence, we're not going to be reaching for that second or third line tiered drug that's maybe not on somebody's formulary that can cost the patient a huge amount of money, and we're often not aware of it. So, and we need to do a better job of knowing what the cost is and the burden on the patient, because the patients don't want to tell us that they can't afford it. They're embarrassed.
Right. So we actually have 3 new questions that have just come in. The first one is, you highlighted the concern with compliance officers and risk managers and their resistance to many of these initiatives. Any advice on how to handle the resistance that comes up?
That's a great question. And in our unit, we are also convening compliance officers, because they have a huge role. And if they are, if their job description, if their boss is saying whatever, your only mission is to make sure we don't get into trouble, that's a cultural problem, right? We need to make sure that leadership tells the privacy and the IT and the compliance, and the whole organization understands that these are important, the regulations and doing things correctly, but not at the expense of the misuse of our nurses and our doctors' time. So it's often driven by fear. And we do need to work closely with our compliance officer. They're trying to do the right thing. They're trying to do their job. And so understanding their culture and not pointing at them as, it's all their fault. You're making my life miserable. That's not why they go to work every day. So asking them and working with them to say, well, where is that regulation, right? And that's where I would refer you back to the Debunking Regulatory Myths, because we link directly to where the rule is from CMS. And as I mentioned last month, this de-implementation checklist, which is under the Gross Toolkit, under resources, has just gone viral. And that Joint Commission reviewed that and endorsed it, is huge. So that's getting passed around. Send it to your AMA. All these things are downloadable. Send it to your compliance officer. Right. But work with them. We don't want to butt heads. Little steps of change, and then thank them if they make a change that is better for all and improves the value of the whole experience.
Great. So the last 2 questions, the first one is, Dr. Ether asks, advice on consultations, I get 50 a day. And so I'm not sure, Dr. Ether, if that's from patients or from other physicians. When you say advice on consultations, I get 50 a day. If you're able to get on to the Q&A and be a little bit more specific, that would be helpful.
Either you're receiving a consult or you're a subspecialist and asking to be consulted and you can't meet that need. Either way, rethinking the workflow. And it's just such a habit, and it's a courtesy amongst us, our colleagues, when we've relied on snail mail to copy the chart. So I understand the subspecialists wouldn't want to not send a thank you note, but once you're all using the same chart, it really isn't necessary. It's a holdover from carbon copy. CC means a carbon copy. That's 30 years ago. If you are a subspecialist having not able to meet the needs of all the referrals that you're receiving, that's workflow, that's access, right? That is, and a lot of organizations who are doing virtual consult with the primary care doctor there. So the patient is in the room, I'm in the room with the patient. I have a quick question about a heart rhythm or something, or a medication, and I get my GI consultant that already knows the patient on the phone. But then you have to have a system where they're reimbursed for that time as well.
So I think she just highlighted the issue. The issue really is she's a primary care physician, and because of her patients seeing other consultants, they're copying her, and her system is requiring her to review the notes because that's the way the system's set up to show, under perhaps some old Joint Commission belief that, well, you know, you need to be aware of what's going on. And so the question is how to deal with that in her system, where she's being overrun with all these inbox consultations that she's supposed to review and sign off.
Right. And that was my experience. And as I said, I didn't need to see them. I trusted my colleagues. I would review it if I saw that it was about to see the patient. That's when I want to see what the cardiologist said or the pulmonologist. So it will, to change it, you probably have to have a one-on-one conversation with your subspecialist because they have an opportunity when they finish their note, and it's probably defaulted, to automatically send their note to you, and they just have to unclick it.
Right.
But
as a cardiologist, there is a training issue that we have been trained to keep the primary care doc in the loop. And so I think it does highlight, if you're all part of the same system, that needs to be a conversation at department chair, division chief, everybody saying, okay, if they're within the system, you don't have to copy. But if it's somebody outside the system, you know, keep them in the loop, because we're still not at pure interoperability.
Right, and it's not all or none, right, Jim? Because if there's one person that you want to know specifically, they're going to see the cardiologist, I want to know if they're going to put him on a blood thinner or whatever, just send yourself a reminder,
right? You know,
to ask the cardiologist in a week.
And the last question is one we're kind of short on time, but how does one deal with the state rules on scope of work for all the team members? Any suggestions on how to address that?
Well, it'd be 50 different ways, right? Because there's probably 50 different. But it's worse than that, actually, because even here in Chicago, the scope of work for a medical assistant differs on what side of the street you're on. Right. At a university hospital, for example, the MAs give immunizations. Because of a stronger nurses unit and scope of work issues, that organization prohibited it.
Right.
So you start with the state legislation, but it is often overinterpreted within your organization. Excuse me.
And I think that's the great the wrap up is that each individual organization, whether you're in a small independent private practice or you're part of a large system, the AMA has resources to help you improve your functioning so that you can spend more time with the patient and have your team members work at the best top of their license, as they will, or top of their regulation. So Dr. Brown, we want to thank you very much for your wisdom and your experience and the great input. We'd like to thank Brittany and Casey for their help from an IT standpoint, and to all on our viewers, our 66 people that finally logged in. Thank you very much. And again, this will be available. Resources are available right now if you go to stepsforward.org. Have a wonderful day.